Okay, before we move into lecture four, we're going to start talking about some ABO discrepancies where your forward and back typing does not match. Okay, that's a discrepancy. Before we transition into that, I want to review and make sure everybody understands how your forward and reverse reactions should look in normal situations. Okay, so let's go through these examples really quick. Notice in this example, you have a 4+ reaction with anti-A, anti-B, and anti-A, B. So what's your forward type? AB. What do you expect your back type to be? Both negative, because your A and B antigen are both being expressed on the cell. And remember Landsteiner's rule, if you lack the antigen, you can build the antibody. Okay, so this patient has both the antigens, so they are not going to build any of our ABO antibodies. That's why they're negative with the A cells and the B cells in the back. So this patient is typed as AB. All right, let's look at this example. 4+ with anti-A, negative with anti-B, 4+ with anti-A, B. What's your front type? A. What's your back type? Still typing as an A. This is what confuses patients. Remember, in the back type, you're using patient plasma where the antibody is. Okay, so this patient has the A antigen on their red cells. They're going to have the B antibody in their plasma. The B antibody will react with B cells, okay, not A cells. And that's what confuses students, and that's why they often want to say this patient is a B. That's not right. We always type our patient by what antigen is present in your front type, okay? So this patient is A, okay? So in this example, we have a negative reaction in our front type, anti-A, anti-B, anti-A, B. In the reverse type, we have 4+ reaction with both our A cells and the B cells, meaning this patient has both anti-A and anti-B in their plasma. What type? O. And then we have a negative reaction with anti-A, 4+ reaction with anti-B, a negative reaction with anti-AB. What's our front type? B. And then your reverse type, 4+ reaction with A1 cells, negative reaction with your B cells. That's your B type, all right? So in all of these examples, your forward reactions match your reverse reactions. What's the type of this patient? B, okay?
You have a reaction with anti-A, B.
You should. Yes, that should be 4+ there. Anti-A, B will react with the A antigen and the B antigen. So on your A patient, your B patient, and your AB patient, you will always have an A, B reaction. A, B does not react with O cells, right? Because the O patient lacks both the A and the B antigen. Okay, so when we start thinking about ABO discrepancies, I want you guys to break this down. I want you to look at your forward type. Ask yourself, what is my forward type? What antigens are present? Then I want you to look at your reverse type. Ask yourself, does it match? Does it make sense? One way that you can always identify which reaction is probably not correct or is the problem, they will have a weaker reaction. If you guys noticed in the previous examples, all of our reactions were pretty much 4+. Sometimes you might even see 3+. Our true ABO reactions are always strong like that. Remember the ABO, they're very antigenic, okay? And so they will always have strong reactions. As we start moving through these discrepancies, you will notice that your reactions, the ones that are discrepant, are going to be like 1+ or 2+. They're going to be a lot weaker, okay? So keep that in mind. So if you guys have ever watched some of the medical shows and they said type and screen, your type is your ABO-RH. Your screen is determining if there's any non-ABO antibodies in the patient circulation, okay? So you always, on any testing that is done in blood bank, we will always perform the ABO-RH. And the ABO will consist of your forward and reverse typing. Part of that report, when you report out a patient's ABO, you want to make sure there's not any discrepancies. Okay, if there are any discrepancies, it's very important that we figure out what discrepancy is going on. For instance, if you have a patient that has a reaction in their back type with the A cells, that's not normal, right? That looks like a type O patient, the back type does. So more than likely they're a subgroup of A. If you miss that subgroup of A, maybe they have their A1 or A2 with anti-A1. If you were to give them a normal A1 unit, that patient's anti-A1 is going to attack the donor cells. You're going to cause a transfusion reaction for that recipient. Okay, it's very important if you have a discrepancy to stop right there and resolve the issue. Okay? If you're ever in an emergent situation, patient's in the OR, bleeding out on the table, physician is yelling for blood, what are you going to do? You can give them O negatives, okay, until the ABO is resolved. Okay, that's a true scenario that happens all the time. If there's a discrepancy or your patient has an antibody, they're screaming at you for blood, you're like, I can give you uncross-matched O negative blood right now. They have to sign for it. They're taking responsibility for the patient. Okay. There is an exception with that forward and reverse typing on all of your patients, except for when you are doing cord blood testing on a newborn or a venous sample on a newborn that is less than 6 months of age. They only get forward testing. So you'll only do anti-A, anti-B, anti-A, B, and then when we add on the RH, you'll do that. Okay, and the reason for that is because babies will not build antibodies until about 6 months of age. Okay, so we can't get an appropriate back type on those patients until 6 months. If you encounter a discrepancy, the first thing you should do, double and triple check your patient. Okay, check your sample tube. If it had been relabeled, pull the top label off, make sure it matches. Make sure the right patient was drawn. The number one reason for errors in blood bank, what do you guys think it is? Mislabeled clerical error. Somewhere that specimen was mislabeled, whether it happened during the phlebotomy process, the wrong patient was drawn, whether it was relabeled in the lab wrong. Okay, that's the most common reason for error in the blood bank. Seems simple, right? But I promise you it happens all the time. Okay, so as a blood banker, you will become very anal. You will double and triple check everything. Okay. Another reason that often happens is in lab this afternoon, you guys will see this, how your blood bank rack is organized. Oftentimes, if you separate your sample, so you have your red cells in one tube and your plasma in the other tube, and then you have them patient lined up right next to each other, it's very common, especially for new techs, to add the plasma from the wrong patient. So then they have a different forward type from the reverse type. They think they have a discrepancy, but in reality, they use the wrong patient plasma. Okay, so another reason is you want to repeat that testing before you diagnose your patient with a discrepancy. Make sure, double check your samples, and then repeat that testing to see if you get the same results. So that's the first thing, as you guys go through blood bank lab and you tell me you have a discrepancy, that's the first thing I'm going to ask you. Tell me what you did, what sample did you use, and then we'll troubleshoot from there, okay? All right, so the three most common causes. Number one, you use the wrong reagents. Okay, that's possible. Number two, you used the wrong sample or you mixed up the sample, or there's some type of testing errors. Maybe you forgot to centrifuge, and that will give you a false negative, okay? For the reagents, again, you could use the wrong one. You could use expired reagents where they lose their specificity, so they no longer react as they should. Maybe you even totally forgot to add reagents. That might happen as well. That would give you false negatives. Wrong concentration of cells. If you have prozone or postzone, remember our desired, we want that zone of equivalence to allow for the antigen antibody complex to occur. Okay, so if you have postzone or prozone, those will both cause false negatives. So wrong sample, wrong patient sample. Maybe the patient wasn't properly identified during the phlebotomy process. Maybe the sample was relabeled when it was received in the lab and it was labeled inappropriately. A good rule of thumb for labeling samples when received in the lab, if your lab does relabel, I always, on the original label, leave the patient name and medical record number if possible, and then put your lab label right under the medical record number. That way, both are visible. It's a good way to relabel the sample. Maybe the specimen was not handled appropriately. Maybe there was a delay in testing. Maybe it was on the floor, sat out for several hours before being sent to the lab. That could affect our testing of how the antibodies would react and things like that. So that could affect the results that we get. If you accept samples from, let's say, a hospital that has many satellite clinics, especially in blood bank, if you have any OB clinics where moms are being drawn at about 16 weeks, mom will have her blood drawn to determine her ABO RH. If she is RH negative, she will get ROGAM. And then, so if there's any delay in that testing, maybe they forget to send it for 2 or 3 days, that could alter our testing as well. Because we just don't want it setting out at room temperature. When we receive the sample, we do our testing and then we put it in the refrigerator. Okay. Testing errors, wrong temperature. Maybe you forget if there's an incubation phase. Maybe you forget to incubate. Wrong centrifugation. Misinterpretation of a weak reaction or mixed field agglutination. So if you overshake, and today in lab we're going to concentrate on our shaking technique. So if you overshake, shake too hard, that could cause weaker reactions, maybe with some false negatives. If you don't shake enough, then you could get some false positives. So your shaking technique is very important, and I will show you guys this afternoon in lab. Remember in a previous lecture, we talked about hemolysis being a positive reaction in blood bank. If after centrifugation, you pull your tubes out and you notice a slight tinge of red coloration to your tube and a very small cell button, that is indicated of hemolysis. An antigen antibody complex has occurred. That is a positive reaction. A lot of times in blood bank on our data sheets, we will note hemolysis by an H. Okay. So it's not negative, but it's not graded like 1 + 2 + 3 + 4 plus. We just put an H there for hemolysis. Clerical errors in recording. Let's say you're doing your patient testing, you read your tube reaction, it was negative, but somehow you enter it on paper or in the computer as 4+. All right, so that happens. It's just a mind thing, but you just always want to, that's why we always want to repeat our testing before you report out a discrepancy. Tubes labeled incorrectly. Again, maybe you use your patient plasma, wrong patient plasma, or maybe your specimen tubes don't match your testing tube labels. So labeling is a huge thing in blood bank too, and I will really harp on you guys in the lab about labeling, okay? Sometimes you have to consider your patient history. Where is your patient located? Here at UAMS, a lot of our multiple myeloma patients, a lot of our leukemia patients receive bone marrow transplant. So their types are going to change. So anytime you have a discrepancy in the history, maybe they're previously type B, now you're getting an A, you always want to check. Number one, I would automatically have it redrawn to confirm. And number two, I would ask if they had had a allo bone marrow transplant, okay? And you also want to consider your patient's age. One thing that you'll see as patients get older, their production of antibodies decrease. So oftentimes in either older or immunocompromised patients, their ABO antibodies might not react. So anytime your front type and back type doesn't match, we could try to, if you think their reverse antibodies are not working, we could try to encourage that agglutination. And we have an example that we'll look at like that. Certain diseases, transfusion history, those are all things to consider when you encounter a discrepancy. And then also think about your patient diagnosis. Is there a specific diagnosis where your patient has a lot of excess protein? You guys remember? Multiple myeloma produces excess immunoglobulins, all that excess protein. What effect does that excess protein have on red cells? Lowering the zeta potential, those cells are going to come together and form rouleau. Okay, we will talk a lot about rouleau in blood bank. It interferes with our testing. The cells are going to come together, form that stack of coins. It could be interpreted as a false positive. Okay, so if you look at your test tube under the microscope, you will actually be able to see stack of coins. Okay, that is rouleau. We actually we have an example, and we're going to talk about how blood bank can dissipate that rouleau. Okay. Pregnancy or transfusion issues. If your patient is type B and has been recently transfused with multiple type O units, that could alter their ABO determination. They might have a discrepancy there. So we're going to look at an example like that. And mixed field agglutination investigation. Mixed field agglutination is very hard to see. And what the definition of mixed field agglutination is, you will have one population of cells that is agglutinating, and then the other population is not. This is very hard to see in tube. When we start doing our gel testing, the gel testing is more sensitive and easier to see mixed field agglutination. Okay, so the types of discrepancies. Maybe you have additional reaction in your forward type that shouldn't be there. Okay, we have two examples where we're going to look at that. And again, remember, if you have a discrepancy and you're trying to figure out which result is causing the problem, it's going to be the weaker reaction. Okay, keep that in mind. Maybe your forward type has some missing antigens, all right? So maybe your forward and back type don't match, and maybe your forward typing is missing a reaction, okay? We have an example, we're going to talk about that. In your reverse typing, maybe you have an unexpected reaction in your reverse type. So as you guys look at these discrepancies, you have to ask yourself, that's why I have you guys practice, what's your forward interpretation, what's your reverse interpretation? And now I'm going to ask you, which one is the discrepant result? Why does it not make sense to you? Okay, and you're always going to look for that weaker reaction or maybe the missing reaction. Reverse typing involving missing antibodies. An example of that would be the older individuals where their ABO antibodies are not reacting. And we're going to talk about how we can solve these discrepancies. You have to solve these discrepancies before you can adequately report out a type on your patient, okay? And again, you always want to look at the strengths of reaction, right? Your weaker reaction is going to be the discrepant result. Okay, sometimes in forward cell typing, we have some additional reactions. And one reason for this could be what we call polyagglutination, meaning that in your forward typing, you are using patient cells, right? Patient cells mixed with commercial antisera. If you have an additional reaction in your forward type, it could be that something is coating patient cells, something that occurred in vivo, and it's coating that patient cells, causing it to react with all of our antisera. Maybe like an autoantibody or something like that, okay? That would be polyagglutination. Sometimes we have an example of if a patient has had some type of GI infection, some gram-negative bacilli can remove the sialic acid from the red cell membrane, causing a typing discrepancy. So that's why looking at your patient diagnosis, patient history is very important as well. And then you might have some non-specific agglutination from Wharton's jelly. I don't know if any of you guys know what Wharton's jelly is. In the newborn, in the cord blood, the maternal fetal blood exchange, there is this gelatinous material. It's called Wharton's jelly. It actually is very, it looks like grape jelly. It's very, it's just gelatinous, okay? So when we do cord blood testing, it's very important that we wash that cord blood a minimum of 8 times, okay? And the reason for that is we want to get rid of all of that Wharton's jelly. That Wharton's jelly, it's very gelatinous. It can cause false positives. So we want to make sure that we adequately wash it away. And rouleau as well can interfere with our blood bank testing, causing false positives. Like I mentioned, you might have an acquired B due to some type of GI infection or intestinal obstruction, GI cancer. Usually we'll see this in A1 patients, and we have an example coming up of what that's going to look like. Sensitized red cells. There are a lot of different types of blood bank reagents. Some reagents even use high protein. Using that high protein reagent can cause some false positive reactions. Not a lot of places use that high protein reagent any longer. Now everybody is pretty much moving to monoclonal reagents, and we're going to talk about monoclonal versus polyclonal. We're going to talk about that. Sometimes after a patient receives a transfusion, you might have two populations of cells. So if your patient was B and received some O cells, those O cells could replace your patient's B cells. That could cause a discrepancy because your B antigen is no longer going to be, there's going to be weakened or no longer expressed, and you're going to be picking up those O cells in the forward typing. Okay, so that could cause a discrepancy. If you ever test a patient's blood after they have had a wrong ABO, everything is going to be positive. So you'll definitely have a discrepancy with that. There's also a phenomenon occurring when twins are in the womb. Sometimes blood can occur between the fraternal twins, and that could cause a population, two populations of cells as well. I personally have never seen that, but it is documented. It can happen. We don't typically see that in identical twins, not usually an issue. Okay, so let's go through some examples, and these are actually in your textbook. So I encourage you guys to go through these, practice on your own, okay? Practice going through, looking at the forward type, looking at the reverse type, identifying what the discrepancy is. Okay? So here we go. We have in our forward type, we have a 1+ reaction with anti-A, and a 4+ reaction with anti-B. But if you look at our back type, we have a 4+ reaction with A1 cells, a negative reaction with your B cells. So what's your front type as? AB. What's your back type like? B. Looks like a B patient. So out of these results, which one do you think is causing the problem? The anti-A, because look how weak it is compared to your other reactions. Okay? If this wasn't there, if this was negative, then our patient would be B. Okay? So there's a phenomenon. Remember I mentioned reagents a while ago? Sometimes our reagents are so sensitive that sometimes if you're using like a high protein or something like that reagent, you can get these false positive reactions like this. Okay? And so this is what we call the BA phenotype. So this patient is actually B, but we're picking up a little bit of the A sugar, the N-acetylgalactosamine. All right, we're picking up a little bit over there, and that's because that reagent is so sensitive. Okay. So what we could do is, if you were using a high protein reagent, you could try to do a different reagent. You could try to do a monoclonal. It's a more specific reagent, and that would make that reaction go negative. Again, it's because our B gene is transferring just a little bit of that N-acetylgalactosamine. And the reagent is so sensitive, it's picking up on that. So I want to, right here, I want to talk about polyclonal versus monoclonal. What is typically used in blood banks now is monoclonal because it has a higher sensitivity and specificity. What it does is, how it's derived, notice that it's monoclonal. So only a single clone of antibodies is being produced. That's why it's more sensitive and more specific. versus your polyclonal, where multiple B cells are produced in the lab and the antibodies are extracted. So you have several antibodies that are reacting. Okay, so that's why in the previous example here, if you're using a polyclonal, that's why you could get this weak reaction right here. Okay, if you were using monoclonal, it's more specific for the A antigen, then this reaction would probably be negative. Okay, so in this example, we would want to try to use a monoclonal low protein reagent. And then here's an example of how these antibodies are derived. They're usually lab created, so they can take some type of host. Some vendors use mice, some vendors use rabbits. And so it just depends, but they're going to inject these animals, and the animal's immune system is going to produce these antibodies. Okay, so those B cells that are producing the antibodies are extracted. They're combined with tumor cells. So now we have what we call a hybridoma. So these hybridoma cells are producing antibodies. We will extract those antibodies, okay? And it's a single clone of antibodies. This is monoclonal. And then we can extract those antibodies. And that is how our reagent antisera is manufactured. So let's look at a situation where it's opposite, all right? Let's look at this patient has a reaction with anti-A, 4+, anti-B, 1+. What's your front type like? AB, but your back type, you have a negative reaction with A1 cells and a 4+ reaction with B cells. Does that match your front type? No. So which of our reactions do you think is causing the problem? Anti-B, this 1+ reaction here is the discrepancy. So what this probably is, it's a patient but that has acquired the B antigen. Okay, so we call this acquired B. You will see this if patients ever have, and this is why checking history is so important. If you ever have some type of intestinal obstruction, intestinal infection, cancer in the intestines, anything where the gut flora can be exposed, okay? That gut flora, typically it's a gram-negative bacilli, will remove some of the N-acetyl galactosamine sugar from the oligosaccharide, and then it will, D-galactose will also be positive, okay? So that's what's causing this reaction right here, all right? So in this situation, you could run what we call an autocontrol. You could take patient red cells mixed with patient plasma. The anti-B in your patient's plasma should not react with the acquired B antigen on the red cells, okay? And then there's also special reagents that are documented not to react with that acquired B as well. And again, in all my years of blood bank, I never ran across this case, but you might see it. Okay, so those are two examples of where you would have a forward excess reaction, an additional reaction that shouldn't be there. Let's talk about where you have forward cell reactions with a missing reaction. And the most common reason you will see this is a subgroup of A. Do you guys remember in lecture 1, I mentioned that there were hundreds of subgroups of A that could occur. Typically for a straight A patient, they're A1, and there might be A2, but there's also AE, AX, A3, there's many of them. Typically with those subgroups of A, remember we talked about how they have a weaker antigenic expression. Okay, so if they are a subgroup of A, that anti-A reagent is going to have a very weak or missing reaction, okay? So what it looks like would be something like this, all right? So you have a negative reaction with anti-A, negative reaction with anti-B. What's your front type like? That looks like an O, right? But your back type, you have a negative reaction with A1, which is not what we would see in an O patient, correct? And then a 3+ reaction with your B cells. Okay. So what is missing? One of our reagents that is actually not included on your front type testing. Anti-A, B. All right, so A, B. So what we could do, your first step in resolving this discrepancy, run anti-A, B. All right. If your anti-A, B is positive, all right, remember A, B will react with the A antigen and the B antigen. It is used to confirm group O's. All right, so if this was a group O patient, maybe where their A1 cells were not reacting, it should react with, it would not react with A, B, right? However, it might react with A, B, then you know you have a weak subgroup of A. And it's all because you have a subgroup of A that has a very weak antigenic expression. So we're not picking it up with our testing techniques. What is, let's see if you guys can answer this. What other testing could you do on this patient to confirm that it is a subgroup of A? You could do a molecular genotype. That's probably a good idea for this patient if you're trying to identify exactly which subgroup it is. But what about A1 lectin? You guys remember we talked about that? It's a plant extract. It will react with the A1 antigen. So if you have a negative reaction with A1 lectin, that lets us know that our patient is not A1, that he is definitely another subgroup of A. Okay. There's actually something else we run in conjunction with A1 lectin. Do you guys remember what it was? A2 cells. So anytime you run A1 lectin, you will always run A2 cells. Remember, A2 cells are a reverse test. So you're taking reagent A2 cells mixed with patient plasma. Would an A1 patient react with A2 cells? No. Would a A1 patient react with A1 cells? This is tricky. You want to say yes, right? If you have an A1 patient, that means they have the A1 antigen. Can they have anti-A1 in their plasma? No. Okay, so the only types that react with A2 are B and O. That is the only two types that you will have a reaction with A2 cells. Students always want to say A1 patients react with A2 cells, or A2 patients react with A2 cells. That's not correct. I know you want it to be, but you have to think about it backwards. A1 patients have the A1 antigen, okay? A1 patients cannot build anti-A2. You guys remember I told you that? Remember, A2 cells, you're mixing with patient plasma, you're testing for the antibody, okay? A1 patients cannot build anti-A2. And if you're A2, that means you have the A2 antigen. If you have the antigen, you cannot build the corresponding antibody. Okay, so A2 patients will not react with A2 cells. Only B and O. Why? Because B and O lack the whole A antigen structure. They lack the whole thing. So they can build anti-A2. Okay? Does that make sense to everybody? So what you would want to do when you have a subgroup of A, definitely want to make sure A, B is included in your testing. Don't be surprised if you enter your internships or start working in a blood bank lab and A, B is not routinely used in your front type testing. Okay, you usually only add it on when there's some type of discrepancy or they're trying to resolve a subgroup of A or confirm a group O. Okay. Your textbook mentions the possibility if this scenario is still negative with anti-A, B, probably some type of subgroup of A. And what you can do is you can take your reagent anti-A, incubate it with patient cells, let it set for an extended period of time. The patient's antigen is going to bind to your reagent. And then you could do a series of treatments, what we call an elution, where we could break that bond between the antigen and antibody, and then we could see what was attached to the patient red cells. And then we would probably pick up a little bit of the anti-A there. That would mean that your patient had the A antigen. That could confirm that your patient was A. That's a very advanced blood bank topic. Most oftentimes what's going to happen, you're going to run A1 lectin, A2 cells. You're going to prove that your patient is not a group O. You're going to call them an A subgroup. Anybody have any idea of how you're going to transfuse that patient? So you could spend time in reagents, phenotyping all of your group O donor units on your shelf, or you could give them what? You could give them O. All right? That will work. Because why? Because the O cells that you give them lack the A and the B antigen. So the patient, if they have built-in anti-A1, it won't attack the donor cells. All right, so there's another one. Let's say you have an additional reaction in your reverse type. It could be due to some type of cold reacting allo antibody. And a very good example of this is anti-M. He's a cold reacting. It could be P. It could be Lewis. All right. So what's happening here, think about your A cells and your B cells. Those are actually donors that have donated those cells. We know they have the A1 antigen and the B antigen on the cells, but they also have other antigens expressed as well. So if there is a room temp, because that's the temperature that we're doing all this testing out, if your reagent cells are also positive for one of these antigens that is reacting at initial spin, then it could cause an interference with our reverse typing as well. And I have an example of that coming up. Rouleau, I mentioned Rouleau earlier too. It can cause false positives. Rouleau is oftentimes mistaken for agglutination, and it will cause false positives as well. So here's an example of what Rouleau would look like. And remember, Rouleau is due to excess protein in the plasma. So it is going to affect our reverse reaction. Okay, so take a look at this example. Anti-A is 4+, anti-B is 4+. What's your front type as? AB. But your back type, take a look at your back type reaction. A1 cells is 2+, with B cells is 2+. Does that match your forward type? No. But notice, it's not just one additional reaction that we have here, it's both cells. Okay, so that makes us think something in the patient plasma is reacting with these cells. Okay, so you could think of maybe a room temp reacting allo antibody or Rouleau. Okay. If you think about Rouleau, there's a test in blood bank that we can do. It's called the saline replacement. You will take these two tubes, you will spin them down. You're going to remove patient plasma. If the antibody is there, it's already bound to the cells, right? You can remove patient plasma, add 2 drops of saline, recentrifuge, and then read for agglutination. The Rouleau should dissipate, but your true agglutination, the antigen-antibody complex, should still be there. Okay, that's called saline replacement. So in this example, if we do the saline replacement, repeat our testing, these 2 tubes should both go negative. Okay. And remember a couple lectures ago, I told you to never look at your ABO interpretations under the microscope. Okay. In typical situations, you wouldn't. In this case, if you were to look at these 2 tubes under the microscope, what would you see? You would see the stack of coins. You would see Rouleau. All right, and that's another way you could say, hey, this patient, that's not true agglutination, that is rouleau. Okay, that's another way. And then you could do the saline replacement. It would disperse these results. It would give you your negatives, so then your front and back match. You would definitely want to put a comment in your patient chart that rouleau is present and that saline replacement was performed. Okay.
Would you not have that information ahead of time?
Maybe not, if this is the first time you're seeing this patient. So another thing that you're always going to do in blood bank is you're going to check your patient history. See if you have a previous typing on file. If there's any notes, if you already done this patient and you know this patient has rouleau, you're still going to have to resolve this discrepancy. You'll still have to perform the saline replacement. Make sure these reactions go negative, then you can report out your type. So actually, you guys will have to do a type and screen if you have a patient that's in the hospital and they're consistently getting products or being treated. They have to have a new typing screen done every 3 days, every 72 hours. And that's just to maintain their immunologic status, especially if they're being transfused. We want to know if they are actively building antibodies.
I guess I was just wondering if it's not screened by hematology first before it even comes over to blood bank.
If blood bank and hematology communicate with each other, you might ask hematology if they picked up on any rouleau or anything like that, but we still have to resolve our testing. And just to note, remember that rouleau affects the patient plasma testing. So also what's going to happen when you do your antibody screen, it's also going to be positive as well. All right, so it is going to affect not only your back type, but your IAT as well. So we actually see this quite a bit at UAMS, see rouleau with our population of multiple myeloma and Waldenstrom's, because they have the abnormal clone of plasma cells that produce the excess immunoglobulins. Remember, it's that excess protein present in the patient's plasma that breaks down the zeta potential of your cells, causing them to easily come together, forming that rouleau, okay? And this took this from your textbook. It just kind of breaks down what's going on with the saline replacement. So you spin down those reaction tubes, remove that patient plasma, replace it with saline. If there's no agglutination remaining after your saline replacement, then you know it was rouleau. Then agglutination might still be there, right? So that antigen antibody complex has already occurred. The antigen is attached to the red cells. So we should still be able to see that agglutination. So here's another example. This is a group B patient transfused with multiple O red cells, okay? So notice that we have anti-A, a negative reaction, a very weak reaction with our anti-B, and then a 4+ with our A1 cells in the reverse type, and a negative reaction with our AB cells. So what's your front type like? B, but what's your back type like? It's also a B. But why is this reaction so weak? That's right, because your patient has been transfused with multiple O cells. So those O donor cells are now in the patient's circulation. So you have more donor cells than you do patient cells. And remember, O cells lack the A and the B antigen. So these O cells, we're only picking up a few of our patient cells here. That's why this reaction is so weak. Does that make sense? I mean, what you would want to do on that, you definitely would want to look at your history and confirm that this patient had received multiple O units. This is probably not going to happen after just one transfusion of an O unit. This is going to have, maybe he was involved in a motor vehicle accident, some type of trauma, and he received multiple units, okay? So here's an example versus agglutination versus rouleau, okay? So you guys all know agglutination looks like a cluster of grapes. And so we are able to visualize agglutination in our testing tubes. If you were to look under the microscope, you would actually see like clusters of cells together. Versus rouleau, if we were to look at the cells in rouleau, then you would actually see the stack of coins. Okay, so that's the difference between agglutination and rouleau. Sometimes this is what's happening in mixed field agglutination. You have some cells that are agglutinating and some cells that are not. You have a really hard time in tube testing differentiating mixed field agglutination. It's hard to do. Typically, what is going to happen is this is going to be graded as a weak reaction. Like in this example here, they noted a little bit of a mixed field reaction, but they graded it as 2+. So what you're really going to pick up on in the mixed field agglutination, you're going to see just a weak, it's going to be a very weak reaction. Okay. All right, so remember, we talked about if you have some additional reactions in your back type, it could be due to rouleau. It could also be due to some type of cold reacting, either an allo antibody or an auto antibody. So take a look at this example. You have anti-A with a 4+ reaction, anti-B with a 4+ reaction. What's your front type? AB. But then in your back type, you have a negative reaction with A1 cells and a 1+ reaction with your B cells. Is this what you expect for an AB patient? Now, which one of these results do you think is discrepant? B, right here. Okay. Do you think that this was due to a patient patient antibody? Do you think it's an auto antibody or an allo antibody?
Allo.
Why?
Because I would get positive for those.
Bingo. Okay, so if you have an auto antibody, it would react with both of these cells. Okay, because we only have one reaction here and it's not reacting with this cell, it could be due to a cold reacting allo antibody. Okay. So what do you think? What do you think your patient's type is? AB, all right, with your reaction in the B cells being a discrepant result. What would you do at this point? How could you resolve this? What did you say? Not necessarily redraw. You could warm it up. All right, so this is a cold reacting antibody. We could incubate these at 37 degrees and then repeat our testing. That 37-degree incubation will dissipate this reaction. Okay? We could also run a panel. Right? If we think this patient has an allo antibody, we need to identify that antibody. Okay? And so we could run a panel on this patient as well. And so you could test patient serum or plasma with screening cells. That's your antibody screen. That's your IAT. Okay? And that will let us know what antibody is reacting in the patient cells. One way you could resolve that, once you identify the antibody, you could also find B cells that are antigen negative for whatever the patient's antibody is. Right? And that would resolve that discrepancy. Okay? So let's say this patient has anti-M, which is known to react that initial spin. You could find a group B cells that are M negative. Okay, so that patient's anti-M would not react with the B cells. That would give us a negative reaction that would match his AB type. Okay, that's what you could do. When we talk about auto control, what you could do is you could take your patient plasma, mix it with screening cells. Okay, that could be screening cells 1 and 2. You could also take patient cells mixed with patient plasma. That's your auto control. If your screening cells 1 and 2 are positive, but your auto control is negative, that lets you know that you're dealing with an allo antibody. right? If your screening cells are positive and also your patient cells mixed with patient plasma is positive, that's an autoantibody. Okay, that means your patient has an antibody to his own cells, causing your patient cells and patient plasma to react. Does that make sense to everybody? That's an autoantibody. That's how in blood bank we can differentiate an alloantibody from an autoantibody. And you guys will get plenty of practice with this. So if you're feeling overwhelmed right now, it's okay. It's going to kind of all come together, all right? So autocontrol, also referred to as autologous control, patient plasma mixed with patient cells. That's your autocontrol. If your autocontrol is positive, that means that the patient has an antibody to something on the patient's cells that's causing agglutination. That's an autoantibody, whether it be anti-I, whether it be drug-induced, whether it's just the drugs causing the patient to have a positive DAT, positive autocontrol, okay? If your patient has an autocontrol, if it's a cold reacting autocontrol, you could warm it up to 37 degrees. Those reactions will probably dissipate. If it's a warm reacting autoantibody, then it causes huge problems for blood bank because it's going to interfere with all of our testing. When we do our antibody screen, we do our panel identification, our DAT is going to be positive, our elution is going to be positive, everything is going to be positive in a warm auto. Okay? In a cold antibody, we can usually get rid of those reactions. Right? All right, let's talk about a subgroup of A where they have built anti-A1 and what that looks like. This is the most common discrepancy that you will see in blood bank, okay? So here we have a group A2 patient with anti-A1. Notice in your front type, you have a 4+ reaction with anti-A, a negative reaction with anti-B. What's your front type like? A. But in your back type, notice that you have a reaction with both A cells and B cells. Okay, that A1 cell reaction is actually weaker with 2+. Which does your front type and back type match? No. Which of the results do you think is causing the problem? It's your A1 cells. All right. So you have a patient that has an unexpected reaction with your A1 cells. What's your first thought? Yes, definitely a subgroup of A. Okay, so you have to prove that. So what cells are you going to run? A2 lectin and A2 cells. Okay, anytime you run A1 lectin, you have to run A2 cells. All right. So if you run A1 lectin and you get a negative reaction, what does that tell us? Is your patient A1 or not? It's like with a negative reaction. A negative reaction with A1 lectin tells us our patient is not A1. They are a subgroup of A. Okay. What type of reaction do you expect with A2 cells? Do you think so? So if your patient is a subgroup of A, possibly A2, do they have anti-A2 in their plasma to react with A2 cells? No. Remember, only B and O will react with A2 cells. Okay? So running the A2 cells proves that you're not dealing with a O group, right? You're not dealing, so typically, remember in subgroups of A, this would be weaker. This reaction could be weaker or even missing. Okay? So that's why we would always want to run A1 lectin and A2 cells. So we have a negative reaction with A1 lectin, negative reaction with A2 cells. We know our patient's a subgroup of A. How do you explain this? What reacts with A1 cells? What are you testing here? Patient antibodies. What antibody would react with A1 cells? Anti-A1. So we have a subgroup of A, probably A2 because it's the most common subgroup with anti-A1. Okay, so in your interpretation, you will see this, all right? You have to explain what type of A it is, but do not forget about this reaction, okay? So this patient is A2 with anti-A1. You have to explain this. Does that make sense to everybody? A lot of people will just say, oh, that patient's A2. But you don't explain this, okay? Patient's anti-A1 is causing this reaction. Does that make sense to everybody? You guys will see this in lab. You'll get plenty of practice with it. You'll be very comfortable, I promise. You could also see this. What if your patient was AB? Meaning that you had a 4+ reaction here, 4+ reaction here, but this was negative. But you still had this patient. You still had this reaction. You can have A2B with anti-A1. Okay? For those A2B patients who have built anti-A1, do you think they would react with A2 cells? Why? I said B and O react with A2 cells. Why would AB not react with A2 cells? Because they have the A antigen, all right? They're not going to react with A2 cells because they cannot have A2 in their plasma, okay? That often causes confusion for students as well.
Is that for your having A2 with B?
So the most common discrepancies you'll see in blood bank, you'll see subgroups of A. It'll give you this reaction. You'll have this quite a bit. You'll run A1 lectin and A2 cells. You'll identify your patient as a subgroup of A. Anti-M is notorious for reacting at room temperature. He will interfere with your back type. I saw that a lot in blood bank. And so you'll have that. Rouleau, you'll see that a lot. You'll do the saline replacement a lot. If you have a patient that has been transfused a different type multiple times, like that B patient that was transfused with multiple O types, that could affect your testing. Depending on what hospital you work at, if you do a lot of bone marrow transplants, you could have patients that are changing types. I saw that several times here at UAMS. And so we'll talk about that later on, like how we transfuse those patients. But the acquired B and the BA phenotype, you probably won't see those very often. So here's your results with A1 lectin and A2 cells. Again, this negative reaction with A1 lectin lets us know our patient is not A1. If your patient is not A1, they lack the A1 antigen, therefore they what? They can build the antibody, okay? Remember Landsteiner's rule, you can build the antibody to which the antigen that you lack, okay? For your reverse typing where you have missing antibodies, again, the most common reason for that is you're going to be dealing with an older patient where their immunoglobulin production has decreased, their antibody production has decreased. So you'll see that, and immunocompromised patients as well. So any patients on chemotherapy, they're immunocompromised, so they might have a weak or missing back type as well. So what do you do for those patients? Notice in this example, what do you think about this guy? He's negative with anti-A, negative with anti-B. So what's his front type? O. But his back type, is that what you expect for an O patient? No, he actually looks like an AB patient, right? All right, so typically when you're dealing with discrepancies, your front type is more likely going to be correct than your back type, okay? So the first thing you want to do with this guy, he has very weak ABO antibodies reacting in his plasma. So we could actually, if you guys don't know this already, you could actually enhance the reaction of IgM antibodies by cooling them, all right? So you could incubate these tubes at 4 degrees for 15, 30 minutes, and then recentrifuge them for agglutination. Okay, that cold temperature enhances an IgM antibody. It could make these reactions what we call pop out. It can make them go positive. Okay, so then you incubate these 2 tubes at 4 degrees. You get 2+ reactions on both of those. Then our type matches, right? We have forward typing O, forward typing, backward typing as an O. That resolves our discrepancy. And then so you definitely would want to put a note in the chart. You would put the patient's weak fat type, A cells and B cells incubated at 4 degrees for 15 minutes. Okay. Anytime you do any additional testing, if there is not a place to record the additional testing, like anytime you do A1 lectin and A2 cells, even if you're using a computer, there's going to be truth tables built in where you can enter those results. Otherwise, if you're just writing it out, you'll have a place to record those results. Sometimes if you do a saline replacement or if you do any type of additional incubation here, there's not really a place to record those results. So you could just make a note in your patient chart. Depending on what type of blood bank computer system you have, or if you're doing all paper, just depends on what type of lab you're working at. Most places now will probably have some type of electronic blood bank system. And again, this is also what you would look like. So I'm making the assumption this patient's older. We don't have his age, but I would assume he's either an older patient, maybe a patient that had chemotherapy, and his ABO antibodies are very weak. All right. But if this was a newborn, the same thing, this was what would happen if you did reverse typing on a newborn, right? Remember, because they don't build their antibodies until about 6 months of age. Any antibodies that the newborn has, where do you think it comes from? Mom. Okay, so when we start talking about mom and babies, when the baby has a positive DAT due to an antibody, it came from mom. Okay. So this just lets you know you could incubate your cells at 4 degrees. You could do your A1 cells, your B cells. You could run a auto control to make sure that by incubating at 4 degrees, you're not inducing some type of cold reacting antibody. And then it would be a group O. If your auto control turns up positive, then that lets us know that you do have some type of cold reacting antibody there. We will talk a lot about autoantibodies in future lectures. So as you guys are reviewing this lecture, I really want you to concentrate on subgroups of A, what it looks like if your patient has been multiply transfused with a different type, rouleau. Those are the things to spend some time on. When we start talking about antibodies, we will get back to these cold reacting autoantibodies. Okay, we'll spend a lot of time in the antibody section on those. Okay. So as we've gone through these examples, I've asked you a series of questions. That's really good practice as you are trying to solve these discrepancies. I encourage you to practice this on your own at home. In your data lab sheets in lab, there are several questions where you have to provide the expected reactions for each type. And then you also have to look at the reactions and do the type. Please practice those. Make sure you can do those on your own. Take that blank sheet of paper, practice, and then check yourself. And make sure you get the right answer. That's a really good way to practice. Remember, you always want to look at the strength of reaction. If you have a discrepancy, the weaker reaction is the one that's causing the problem. Ask yourself, is it due to a missing antigen or is it due to an additional reaction? And then how can I resolve that? What's it most likely due to? Is it an A patient, that subgroup of A that's built anti-A1? Is this rouleau? All right, so those are kind of questions you have to ask yourself. Blood bankers are very good problem solvers, okay? And so you guys have to practice and get used to that. Thinking about blood bank, forward and reverse. What's causing my problem? That weakest reaction, we want to get rid of it, all right, if it's an additional reaction. How can I resolve that? And then don't forget to look at your patient history. If you have patient history and your patient is 93-year-old, well, he's an older patient. If his reverse reactions are weak, then his ABO antibodies are probably not reacting. So maybe we can incubate it either an extended time at room temperature or put it in the refrigerator for about 15 minutes. Also look at where your patient's located. Are they a chemotherapy patient? Have they received an allo bone marrow transplant? And when I say allo, that means from a donor that is different from themselves, right? So it could potentially be a different type of bone marrow transplant. Okay, that will cause him to start changing types. What do you do if you experience a discrepancy? Number one, triple check yourself for any clerical errors. A good rule of thumb is to always repeat your testing after you confirm that your patient identification, your tubes all match. Repeat that testing. Make sure it wasn't due to some type of error that you might have made during the initial testing. And then if you suspect a subgroup of A, make sure you test with A1 lectin and A2 cells. In blood bank, we cannot go on assumptions. We have to prove everything, okay? If it's rouleau, you can look for it under the microscope, all right? You can prove that rouleau is there, and then you can do your saline replacement. Saline replacement, remember, dissipates the rouleau. So after saline replacement, if there was a glutination, the antigen antibody complex did occur, it remains. The rouleau is gone. So that reaction should not be due to rouleau anymore. It's due to the patient's true antigen antibody reaction, all right? And then establish a good relationship with the nurses. I cannot tell you how many times I had to call and get patient history on patients, all right? Have they had a recent bone marrow transplant? My experience was prior to electronic medical records, okay? So now UAMS has Epic. We can look up patient history. We could probably find that information ourselves. If, however, your patient history is not very detailed, you can always call the nurse. The nurse can actually talk to the patient. Has she had previous pregnancies before? Has she ever been transfused before? Has she had a bone marrow transplant? What's her diagnosis? Does she have multiple myeloma? That's why I have excess reactions in my back type. All right, those are clues that can help you figure out what's going on with your patient. Okay. Patient identification is very important too. Oftentimes, this happens a lot. Just give you a heads up in blood bank. Females change their names, they get married, all right? So you might have a previous history on Jane Smith, then you receive a specimen, she is now Jane, what's the last name? Cooper, all right? So you're doing testing. Every specimen that we receive in blood bank, we do a historical check on. We will look them up. You can look them up by name, you can look them up by medical record number. I'll go ahead and tell you this, I have my one FDA reportable error in blood bank because a patient was assigned a new medical record number here at UAMS. And when I did my history check, I missed that he was a multiple myeloma patient and he has to have irradiated products to prevent graft versus host disease. So that patient came through the ER, he was probably in some crisis, and they gave him a unit of red cells, and with his new medical record number, he was assigned a new profile in blood bank, and he was issued that unit, non-irradiated red cells. That is an FDA reportable error. I got written up the one time in my blood bank career. So it happened, all right? And it's because the patient wasn't recognized as an existing patient. He was assigned a new medical record number, no history on him, all right? And then I should have recognized his name, but for whatever reason that day I didn't. So you get to know your patients, especially if they're like multiple myeloma, chemotherapy patients who get multiple transfusions, especially those patients that have antibodies and are difficult workups. You'll feel like you will know those patients. I have a personal story about that. I was standing in line at Lobby Cafe here at UAMS and got to talking to the person in front of me. She told me her name. I couldn't tell her this because of HIPAA, but I recognized her name. I had done her workup. So it felt like I knew her. So you'll feel that way even though you're not at the patient bedside. So, but yes, I do have one FDA reportable error. Hope you guys never have to do that, but that was my one time mess up. Oversight. The blood bank's mandated by FDA, if you guys didn't know that. It's the one department of the lab that is regulated by FDA. I just got written up. I got written up, they took it in my employee file. It had to be reported to FDA, so I'm sure the FDA has some type of report on me, and then the patient had to be severely monitored to make sure that he didn't have graft versus host disease. So I think everything was fine for him. I don't think he had any adverse reactions, but it increased his risk by like 90% to have graft versus host disease because he's considered immunocompromised. Luckily, I didn't get fired. No, I mean, it's not like giving somebody the wrong type of blood or anything like that. Depending on what blood bank rules, I mean, I don't think that's grounds for termination, but if it was a consistent occurrence, it probably would warrant retraining, things like that. But I would say in the 8-10 years of blood bank experience I have, the one time, I would rather have a 0 record, but that happened. And I wasn't the only one too. So in blood bank, everything is double and triple checked. So I performed the testing, set the units up on him. The person who issued it also missed it as well. So, but I was the one that got written up. My fault. You know, if that happens, the best thing, really good advice. Best thing is if you make a mistake, admit it. Okay, don't try to hide it in blood bank. If you record a reaction as negative instead of 4+ and you mistype a patient, that's life-threatening. Okay, you don't want to try to make a mistake and hide it. Okay, own it. Say, oh, you know, I entered this wrong. I need to correct my results and give a corrective report to the clinicians. Okay, don't ever try to hide it. All right, so this chart is actually in your lecture manual. It has the reactions of all of our types. Okay, so spend some time on this. You guys get familiar with the expected reactions, identifying any type of discrepancies. Notice that our Bombay type is on here. You guys remember we talked about Bombay? So this is what he will look like. Remember that Bombay, the gene that controls the H substance, he does not produce any H substance. So therefore the L-fucose sugar is not added to the oligosaccharide chain. Therefore, no additional sugars can be added, whether he's type A or B, right? So this is what his type looks like. In the anti-A, remember, no additional sugars were added. So he actually looks like an O, all right, regardless if he has the A gene or the B gene. Okay, we're not able to detect that because no additional sugars are added to that oligosaccharide. And therefore, he does have anti-A1, anti-A1 and anti-B in his plasma. So he looks like an O, right? But notice he reacts with A2 cells. He also has a positive screening IAT. 4+ reaction with screening cells 1, 4+ reaction with screening cells 2. And the reason for that is, if you guys remember, our screening cells, if you notice at the top right there, all of our screening cells are group O. That's because when we are identifying antibodies in patient plasma, we do not want interference from ABO antibodies, okay? So all of your panel cells, all of your screening cells, they will always be group O, all right? What do we know about the group O patients? They do because they lack the sugars on the oligosaccharide chain, right? They only have L-fucose, meaning that they have the greatest amount of H substance, okay? Group O people have the greatest amount of group O substance, all right? So if our patient doesn't have any H, for Bombay patients, they don't have any H being produced. Remember, for what you lack, you can build the antibody to. So this patient has anti-H. Will react with your screening cells because they have the greatest amount of H. Okay, so our Bombay patient anti-H is reacting to the H on screening cells. That's why his IAT is positive. Okay. Bombay type is very rare. I highly doubt you'll encounter it in your career. I've never personally seen it, and if you do see it, please write it up as a case study, and it'll be very interesting. Transfusing those guys is very difficult as well, all right? Remember, because type O has the greatest amount of H. Our Bombay type has anti-H. So really the only desirable way to transfuse Bombay types is with other Bombay types, and it's very rare. So that's why I mentioned Bombay types typically will store their blood in the event of some type of trauma in the event they need some type of transfusion in the future. So if you're Bombay type, you probably know you're Bombay type. Does anybody have any questions? How do you guys feel? If you're feeling overwhelmed right now or not really sure about yourself, keep in mind that's perfectly normal, okay? Again, in lab this afternoon, we're actually going to start seeing this. You'll become much more confident as we build on the labs, okay? But I do encourage you to spend some time with the expected reactions, identifying each type, and then on the discrepancies, especially the subgroups of A. Okay, whether it be an A2B patient with anti-A1 or an A2 patient with anti-A1. Please be able to recognize that, okay? It's a lot of fun for me. Like I mentioned, blood bank is like problem solving, putting a puzzle together, figuring out what's causing the discrepancy. This is every day in blood bank. Like each patient is different. Whether it be solving an ABO discrepancy, identifying an antibody. Luckily in my career, I've actually got to see a lot of rare antibodies here at UAMS. We saw the F I told you about, we identified that. And then work with pathology, what's the best way to transfuse these patients? That's the huge concern when you identify an antibody. We also saw a Diego, which is super rare. And trying to think what else we've seen. But it gets very interesting. And especially if you go on to blood bank and get into the molecular aspects of testing, which is really huge right now. It's very, very interesting. A lot of discoveries being made, especially with the D variant. So I actually miss blood bank. I've actually thought about getting a PRN position somewhere just so I can work on it. I will not lie to you. It can be very high stress. And if you're not good at multitasking, you're not good working under pressure, blood bank might not be good for you. Sometimes we always joke, sometimes it's real quiet, nothing going on, but you never said anything because it was always the calm before the storm. So you can go from doing nothing to have a bleeder in the OR, trauma in the ER, OB patient that's having a C-section. Okay, all of that can happen at one time. The worst experience I ever had in blood bank, two experiences. One was a OB patient. She was having a C-section. She had placenta previa. And if you guys know what that is, the lining of her placenta was attached to her cervix. And so she was bleeding out like crazy. They worked on her all day long. I think she ended up using like 200 products. And so we were giving red cells. We had to call our donor center, get more red cells, thaw in plasma, thaw in cryo. That was at the time here at UAMS, we did factor 7. So we would reconstitute factor 7 and give her a dose. So we did multiple doses of factor 7 to try to control her bleeding. The other time was a liver transplant. They do liver transplant here at UAMS. Typically they don't use a lot of products, but this one liver transplant did not go as planned. And so he was a bleeder as well in the OR. I stayed late that day to help second shift. I can't tell you how many products he used. They actually called in additional staff to help out. So those are my two worst scenarios in blood bank. But it's exciting. It's adrenaline rush, but if you do not handle stress well, I do not recommend it. I for whatever reason, I don't get stressed out. So I don't know.
You're making me really nervous for my internship because my first one is all blood bank. Yep. So
I think you will love it. So as long as you can stay level-headed, understand you're doing everything that you can do, keep patient safety at the utmost center, work with the clinicians, open communication, you'll be fine. But it can be stressful.
So how many heart attacks should I expect? 2 or 3?
We typically, so heart attacks, we typically don't have anything with them. It's the bleeders that are a concern for us.
I meant for myself.
Oh, for you. Oh, okay. And you're not by yourself. I mean, you have a team that you're working with. I mean, certain cases require all hands on deck. Like that placenta previa patient, all of us were working on her. All right, we were thawing plasma, thawing cryo, setting up units, issuing units. So it required the whole team. So. Some days I did not get a lunch. I'll be honest.